Diagnosing infections of the skin. The skin is the body's first line of defense against microbial invasion. It's a dynamic physical barrier. It has a high salt concentration and a low pH, which prevents the growth of a lot of common microorganisms. It undergoes continual epithelial cell turnover, so cells are continuously being produced from the bottom layers of the skin, and they work their way up where they eventually fill with keratin and die as they get toward the surface. And then those cells are going to slough off and be replaced by the underlying layers of cells. It removes substances as well as potentially pathogenic microorganisms on its surface. Colonized with a variety of resident microbes that perform a protective function. The usual biota of the skin adapt to that high salt exposure to the elements and relative lack of nutrients. The normal residents of skin biota are an array of bacteria, fungi, and viruses, and those microbes may act as competitive inhibitors of pathogenic microorganisms. So if they're present, other organisms can't grow. Breaks in the skin allow normal biota to cause infection and transient organisms to enter and cause disease. So any type of wound that's on the skin breaks that barrier, and that's when microorganisms can enter. So typical resident members of skin biota. When we do wound cultures or skin cultures of any type, these are the organisms, if we identify, we kind of just brush off to the side as that's normal flora. And it's really important to be able to differentiate normal flora from an actual pathogen, because the pathogen is what we care about. That's the thing that's causing the infection. That's the one we want to try to treat. While normal biota, we want to keep, and we don't want that contaminating our culture. So Staphylococcus epidermidis, that is the skin bacterium. That is the number one most contaminant that we find in blood cultures. So if we have a blood culture that does turn positive after several days of incubation, and we find Staph epi in the blood culture, it's probably due to not performing the appropriate phlebotomy to get the blood into the blood culture bottle, and that's because the skin biota ended up getting in instead of something that was actually growing in the blood. There's a variety of streptococci as well that cause skin infections. Cutibacterium acnes, which used to be called Propionibacterium acnes, but Cutibacterium acnes and Corynebacterium are gram-positive bacilli. Fungi, Candida and Malassezia, and Staph aureus is a transient colonizer. Staph aureus, if you're a carrier, typically that resides up in the nose, so they can take a nasal swab and see if you have staph in your nose. With Staph aureus, sometimes it can be found on the skin, sometimes not. Doesn't always cause infection. It can just come and go. And if it is present and you happen to get a puncture wound, it can cause infection. Now, Staphylococcus aureus is associated with methicillin resistance, and that's when we get into the MRSA conversation, which we've already covered in this class, but just wanted to make a note and remind you that Staphylococcus aureus is not all MRSA. MRSA is the resistant form of Staphylococcus aureus. Resident microbiota colonization is not eliminated during vigorous washing. The acidic pH of the skin inhibits many common skin pathogens. Bacteria are the cause of most skin infections. Antimicrobial resistance has made them more difficult to treat. Staph aureus is one of the most common. Other bacteria that display multi-drug resistance include Pseudomonas aeruginosa, Enterococcus, beta hemolytic streptococcus, which includes the Streptococcus pyogenes that causes strep throat, and Streptococcus agalactiae, that group B strep that has implications during pregnancy and so forth. E. coli and Enterobacter species. So here you can see the breakdown of those different microorganisms that cause the skin and soft tissue infections. These are the ones that we most commonly see. A lot of times if we're seeing beta hemolysis on a wound culture and we see a lot of it growing, that's more likely indicative of the pathogen or the one that's causing the problem. There are multiple classifications Methods: the appearance of the skin lesion, which provides an important clue about the possible causative organism, and how the infections manifest themselves. So, systemic disease or primary skin process may be further characterized by structure affected and further subdivided by causative organism, bacterial, viral, mycobacterial, fungal, and parasitic. Every time we receive a specimen down in the lab, we definitely need a source added to that specimen so that we know where it's coming from. Pyrodermas. Primary pyrodermas are a group of inflammatory skin disorders caused by bacteria that produce pus. Now, bacteria don't produce pus. The presence of bacteria causes neutrophils to come to the area, and the neutrophils and dead bacteria is what pus is. So if you were to take a swab of pus and put it on a slide and look at it underneath the microscope, you would see a whole bunch of those neutrophils, and sometimes you'd be able to see bacteria inside of those neutrophils. Impetigo is often used interchangeably with pyoderma, but there's other forms of pyoderma that exist. So here's some common primary pyodermas. So impetigo, erysipelas, cellulitis, folliculitis, a furuncle, and a carbuncle, and parenchyma. Erysipelas is a superficial cellulitis that involves the epidermis, dermis, and lymphatic channels. Painful, indurated areas of inflammation with raised borders that are sharply demarcated from adjacent normal skin. Bright red crimson due to hue with fever. Most cases are caused by GAS, which is abbreviated Group A Streptococcus. Other causes are other beta hemolytic streptococci and Staphylococcus aureus. Cellulitis is diffuse inflammation and infection of the superficial skin layers and subcutaneous tissue. It extends deeper in the soft tissue than erysipelas and appears as painful erythema, warmth, edema of the skin with poorly defined margins. Drainage of pus may occur, and then it's called purulent cellulitis, usually caused by Staph aureus, Group A strep. Possible symptoms may or may not be accompanied by fever or other symptoms of systemic infection. Malaise, rigors, headache, elevated white blood cell count are all possible. Predisposing factors: surgery, trauma, or underlying skin disorders. Blood cultures are usually negative. Diagnosis is often made clinically based on the appearance of the affected area. Needle aspirations may be done on selected patients, especially if they're immunocompromised or if they don't respond to their typical antimicrobial therapy. MRSA infections and parenchyma. Community-acquired MRSA infections are possible, and then there's hospital-acquired MRSA infections. Parenchyma is an infection of the cuticle surrounding the nail bed, usually through minor skin wound. Removing a hangnail, nail margin becomes painful, red, warm, and swollen, and pus may be expressed. Folliculitis, inflammation and infection of hair follicles. Staph aureus, purulenta are the most common causative organisms. In immunocompromised hosts, it can also be caused by Candida malassezia or gram-negative bacteria. Lesions appear small. Erythematous papules may be pruritic, and they often evolve to form pustules with whitish or yellowish central zone. Furuncles occur when folliculitis progresses to form deeper inflammatory nodules. They prefer warm, moist areas of the body and areas subject to friction. They're initially red and firm, but soon become painful and fluctuant and generally drain spontaneously. Most common pathogen, Staph aureus. Carbuncles are serious lesions that extend into the subcutaneous fat and consist of multiple coalescing abscesses that can drain at several adjacent sites along hair follicles. Commonly occur at the nape of the neck and the back of the thighs. Symptoms: fever and other symptomatic symptoms. Complications: this could lead to bacteremia or bacteria in the blood. The causative agent is Staph aureus. Particularly MRSA causes more serious cases. Hidradenitis suppurativa It's difficult to treat recurring infection of the apocrine sweat glands, nodular, tender, erythematous swelling that become fluctuant and drain. Often associated with fever and tender lymphadenitis, can also cause scarring. So this one, basically, you get these huge boils that appear on the body, and the boils will grow. They become really bright red. These boils are typically like the size of a nickel or bigger, and then eventually they work their way up toward the surface and drain. So they pop open. If they don't pop open, then they have to be drained surgically. So you can go in and get a procedure done where they basically just get cut open and then they get drained. And then when they heal, they usually produce scarring. There is a genetic component to this, so this typically runs in families. Any type of medication to treat this would be immunosuppressive. So we try to suppress the inflammatory reactions associated with this type of infection. And then sometimes it's treated with long-term course of antibiotics. So doxycycline is one that can be given for a long time. Usually we don't like patients going on antibiotics for a really long time, but if these are serious and significant, then we put them on that long-term antibiotic treatment. Bite infections. So bite infections may be from humans or animals. This is why the source is really important. Bites usually are polymicrobial, which means when you get a bite wound, there's usually multiple organisms inside that wound. Examples of common aerobic and anaerobic pathogens: Staph aureus, Strep anginosus, Eikenella, Fusobacterium, and Prevotella. Diabetic foot infection, peripheral neuropathy, trauma to the feet, inadequate blood sugar control, compromised peripheral vascular circulation caused by diabetes, impairment of kidney function, or improper foot care, so walking barefoot or ill-fitting shoes. They may manifest as cellulitis, typically caused by staph or strep, acute or chronic soft tissue ulceration with or without underlying bone infection, and gas gangrene may be caused by staphylococci or streptococci, or mixed infections of other bacteria, such as Enterobacterales, Pseudomonas, gram-positive bacilli, and anaerobes, notably Clostridium perfringens. Necrotizing soft tissue infection, so infections that produce tissue necrosis and soft tissue gas, can be life-threatening. Categories are based on the level of tissue involvement: superficial, epidermal, or dermal structures, the fascia, or the muscle. Subtypes of infections: infectious gas gangrene, polymicrobial fasciitis, Enterobacterales, and anaerobes. So in necrotizing type infections, sometimes you see blackened tissue, and sometimes it's just bright red and the tissue starts opening up in wide areas. So it looks like someone has literally just been cut open and it's just sloughing off and opening up significantly. Stopping the infection is important, and sometimes amputation is necessary to prevent the infection from spreading further, especially if there's a risk of this getting into the bloodstream, which is a pretty high risk. We want to make sure that we don't have a necrotizing-like bacterium circulating through the blood, because obviously it's going to cause that necrosis all over the body, which can and definitely does lead to death. So monomicrobial fasciitis is typically caused by staph or strep pyogenes. Type 2 is less common, Staph aureus. Younger, previously healthy individuals' infections can involve the extremities. Gas gangrene, type 3, Clostridial myonecrosis, Clostridium species, especially Clostridium perfringens. Other possible causative agents: Vibrio vulnificus and Aeromonas hydrophila. So these are found in saltwater areas, so typically more coastal regions, tropical regions, and around saltwater. And if they happen to get inside of a wound, they can cause some pretty significant infections. Laboratory diagnosis, so swabs generally yield colonizing or contaminating bacteria. We like to get 2 swabs received in the lab. The first swab is for a direct smear and stain. What we're looking for in that is to make sure that the specimens acceptable. So especially if we're looking for a wound culture, we want to see that the swab that we use has very few epithelial cells and a lot of those pus cells or those neutrophils. Deep aspirates and biopsies, those make better specimens. Pustules and vesicles, exudates produce better results. So direct examination, gram stain if bacteria is suspected. Potassium hydroxide, KOH, and or calcofluor white if fungi is suspected. Acid fast if mycobacteria is suspected. Modified acid fast if nocardia is suspected. And fluorescent stains are often performed if warranted. Culture. Enriched media to isolate all organisms and selective media to detect specific pathogens. Non-culture based tests include PCR, antigen detection, MALDI, and serum antibody tests. So wound cultures typically go on SBA, chocolate, and McConkey. Sometimes they also go on CNA. Anaerobic culture is performed only if ordered by the physician. Again, there's lots of normal biota, and it's difficult to differentiate normal from abnormal. But some things that we do to differentiate normal from abnormal is look at the quantity. Pathogens are typically higher quantity of colonies than normal flora. Slide evaluation. Few and no epithelial cells, but many neutrophils. So if we have a specimen and we stain it and it looks like there's very few epithelial cells, but a lot of neutrophils, we know that that is a good culture and we can go forward with performing the procedures on that. Beta or alpha hemolytic bacteria are more likely to be pathogenic than gamma.